TopMedTalk.
Welcome to TopMedTalk. Are you going to be joining us in Philadelphia on the 18th of October? An unmatched opportunity to explore new ideas and innovations, advance your goals, and strengthen your professional circle awaits. It's one of the single largest gatherings of anesthesiologists in the world. It is Anesthesiology 2024, the American Society of Anesthesiologists annual general meeting. It's this year's opportunity to refresh your clinical knowledge and hear from your peers. And if you can't make it there personally, don't worry, TopMedTalk is going to bring you coverage as usual. This podcast is a look back at a small selection of conversations that we've had there last year. Coming up, we're going to be talking about important research on hemodynamic instability, artificial intelligence, the importance of representation in education, sustainability in anesthesiology, and frailty in the anesthesia patient. But before that, let's start with a conversation we had about medication safety. Here we're listening to Desiree Chappell in conversation with Elizabeth Ribello, Executive Director of Anesthesiology, Critical Care and Pain Medicine, the Cancer Network, and Professor, Department of Anesthesiology and Perioperative Medicine at MD Anderson Cancer Center.
So having your pharmacy background and the work that you've already done, I know you're very passionate about medication safety, and that's something we talked a little bit on TopMedTalk about, but I would love to hear more, from your perspective, what we as team anesthesia need to be concerned about. I mean, I know I'm also Vice President of Clinical Quality for North Star Anesthesia, and we put out some recent kind of guidance for our teams around, mislabeling or, making sure you have the right medication that you're pulling out of the drawer and all those things. Right. I'm double checking. But from your perspective, what would you say are the top, things that we need to be concerned about?
It's a hugely broad topic. And anyone that's practiced has either had or medication error, and there's some that continue to occur. And so, for example, insulin overdoses. And so having 1,000 units in a vial where there are trainees is a recipe for error. And so having, that's one area where that insulin could be drawn, in the pharmacy and then brought to the OR for safety's sake. Phenylephrine in a vial. It's 100 times the dose. And of all medication errors perioperatively are due to phenylephrine overdose. Right. And so one of the ways to mitigate that is the pre-filled syringes. And just for so many different reasons, when you think about the medication administration process, right, it's prescription, preparation, dispensing, administration. And as anesthesiologists, we're in a unique position where we're actually doing all those 4 steps at one time. So having a pre-filled syringe eliminates that whole preparation process. Yeah. And so the argument, of course, is that, well, these are expensive. But when you think of a patient, when you think about a medication error and the cost of a medication error itself, it really mitigates that cost. And it's really safest for our patients and also safest for our providers. Because one thing I don't talk about is when a medication error occurs, there's that whole second victim syndrome as well. And so it's beyond, it's a multifactorial issue. And so something easy to think about in terms of how can we make it more simple in terms of how can we prevent the human error aspect of it? How can we provide constraints that prevent us from causing a medication error?
Also last year, we had an important conversation about frailty with Bobby Jean Spicer. She's the Systems Director of Preoperative Medicine at Inova Health, Falls Church, Virginia, and also Professor of Medical Education at the University of Virginia, the author and editor of Preoperative Assessment and Management, which is currently in it's 3rd edition. The subject of frailty is important to us here on TopMedTalk, and these words emphasize that.
And you may say, but it's that Hawthorne effect, right? It's that labeling. We label patients with allergy bands. Okay, we still have to look in their medical record to see what they're allergic to, but we say, that big red band that says they're allergic to something. We label them as a fall risk. Yeah. And we know that these basic, simple things like that have made a difference. Putting something up on the patient's room that says they're hard of hearing or they cannot see well or whatever, right? So I think just start by having an assessment. And if you have an electronic record, it's generally already available to you. Assessment tool that can pull information from your electronic record. Labeling patients as frail. Start to educate people that frail patients need cared for differently. Educating the patient and the family. Is this patient capable of going home and taking care of themselves? A lot of people now don't live close to their family members. They don't have family members to take care of them. We tell people they all have to have a ride home, but then we drop the ball. We just get them home.
Yeah.
We don't tell them what else to do. So I think, basic things. If you don't have access to a frailty assessment tool, there's 2 quick and easy ways to sort of identify a group of frail patients. Any patient who's had 3 or more falls in the 6 months prior to surgery have a 100% risk of a complication in the perioperative period. Of course, falling is a marker of frailty and not doing well. Activities of daily living. There's a very good study out of the VA that looked at activities of daily living, those who were fully functional, those who were either fully dependent on someone else or even just partially dependent on someone else to take care of themselves, bathing, feeding, dressing themselves. These were community-dwelling people, not SNF patients.
Yeah.
And they showed that those who were even just partially dependent on someone else, they looked at the ASA physical status scoring, and it moved them into the higher ASA physical status score. So a 2 independent person who was partially dependent was like a 3 independent person. So, I think just looking at some really basic assessments and then making sure that, you hopefully have some geriatricians and primary care doctors who can help facilitate in those transitions of care back. And then trying to engage your patients in shared decision-making about their goals of care, because many of them, it's not about how long they live. It's whether they can continue to live independently, or they continue to drive if they're driving, if they're going to make it to their, great-granddaughter's graduation.
Yeah, and that's what's important too.
Yeah, and so many of them don't understand. We really don't spend time telling them how long it's going to take them to recover from this total joint. So even sometimes the timing of surgery is not ideal.
Yeah.
Because they think they're going to, it'll be in 2 weeks and back.
Last year, we also spoke about a subject of truly global importance: sustainability in anesthesia. David Havard, GE healthcare consultant, clinical assistant professor at Michigan Medicine, in conversation with TopMedTalk.
Can we talk about the problem for team anesthesia when it comes to sustainability?
Yeah, I think the thing that comes first to mind are the gases that we use.
Yeah.
The patients, the gases tend to get vented straight into the atmosphere.
Uh-huh.
So I think there's 2 main issues that come from that. One are the CO2 equivalents and the impact on global warming. And the second is the ozone layer and the effect that these gases have on the ozone layer. So you can separate those 2 things. There are 4 main gases that we use every day, or we may not use every day, but we have.
Some of us may use more than others. Yeah.
Right? And the big one is nitrous oxide. It does 2 things. It hangs around in the atmosphere for more than 100 years.
Oh, wow.
It's a couple hundred times worse than CO2 per unit in terms of global warming effect or CO2 equivalent. And it breaks down the ozone layer while it hangs around. So it does a couple of bad things. And we use a lot of it. If your flows are at 2 liters a minute for the whole case and you're 50% nitrous, you're using 1 liter a minute.
Yeah, that's quite a bit.
Compared to the volatile agents that we use, probably a few cc's, depending how well you're doing.
Yeah.
The nitrous oxide story is interesting because you don't really have to use it.
Yeah.
You can just use twice as much of another agent. And so when we started to look at what we were using, we realized that we bought about 10 times more than we were giving to patients.
Mm-hmm.
And then when we kind of asked around, it seems that the pipeline that we use in hospitals in general is the cause of that.
Well,
So you can lower your nitrous use if you like, but if you've got a massive tank full of nitrous attached to a pipeline that's working its way through the hospital, it's probably leaking about 90% of what you're using.
our eyebrows are all raised on that.
I've never heard that before. That's quite astonishing.
So I think I've got to pay credit to Dr. Cheeseborough here in Oregon, and he's the one that started a ton of work on this stuff, figuring out where all the leaks are. And essentially, if you just carry on doing what you're doing in nitrous, but attach a cylinder to the back and use a cylinder, you're going to cut your usage by 90%.
No kidding. So instead of piping it through the system, just keeping it in there.
Yep.
Wow.
When we started at U of M, the first thing we targeted was nitrous. We were like, okay, what we've got to do is get the usage down to the point where we can just move away from this pipeline.
Uh-huh.
So we shut the pipeline down. So the first thing we did, we're building a new hospital. It was opening 2025. We took the pipeline out of that hospital. So there was no nitrous pipeline in there. And then a few months ago, we shut off the pipeline in our cardiovascular center. And then today, They're closing it down in the main hospital, which was a great day for me.
Oh, yeah, I'm sure.
Be 2,000 miles away.
Sustainability in anesthesia. A lot of the fun of the conference comes in learning about learning. Last year, we spoke about the importance of representation in education. Elijah McMillan and Majesty Greer, MD candidates at Howard University College of Medicine. They're speaking about the importance of representation in education. They go to Howard University, a historically black college.
Let's talk a little bit about the terminology historically black university or college of medicine, because that, I think, for many people maybe around the world don't understand what that means. So Eli, do you want to tell us a little bit more about?
So it's on par with every other university around the country. It's just universities or institutions that were created to create a space that had equal opportunity for individuals of color and minorities. When we talk about HBCUs or historically black medical colleges, it doesn't exclusively mean that the whole student population is just black students.
Yeah.
There's definitely a huge diversity there as well, but it's an amazing creation that was made to create equal opportunities for individuals to gain access into the educational field as well to help further themselves.
Yeah. And Majesty, what attracted you to Howard? Was that one of the things that brought you to the university there, or?
Yes. Going into medicine, not having anybody in my family who's even like gotten a bachelor's degree, I definitely wanted to go someplace that I felt like I would be included in people that looked like me or came from similar backgrounds as me. And so when I had an interview over at Howard, I really felt like the faculty and the staff had come from similar backgrounds, like I said, just like similar experiences as me, and then talking to the medical students. And I do feel like with me going there, I really have made some like lifelong friends because of that. And I really do feel like I found my community, and that was very important because I needed that support going into medical school, especially because I'm doing medical school in the mainland, far away from my family, so I have to find another support system.
And then as a woman, I can attest to this. It feels good. You feel supported whenever the people who are in leadership represent you and who you are and where you come from. To me, it's hard sometimes to really engage and interact with people who may not understand where I'm coming from.
Now, you don't need artificial intelligence to tell you that this year's conference, like last year, is likely to be abuzz with talk about new AI systems. Here's a couple of conversations we've had on that topic last year at the ASA. Mani Vindhya, Chief Medical Officer at Provation Eye Procedures.
Talk to us a little bit about how the AI is working within your system.
It's funny because we are medically so advanced in anesthesia, in medicine itself, but we're the last adapters of technology in medicine.
Yeah.
And it so happens that when the AI came out, medicine happens to be the first one to adapt AI. This happened exactly about a year ago, November. So it's catching on fire. So there's a lot of buzzwords going on, maybe replaces. All of those are, hype at this time, but it actually can augment in what we're doing. So if having a digital anesthetic record base will really help incorporate AI on top of it, it is actually a big blessing because you don't have to redo anything. You just have to layer on top of it. Once again, lots of abbreviations like LLMs, large language models, voice activation. And so I think AI is going to help augment what we're doing, both on the user interface side and also on the data side in the back end. We're just getting started in this space.
Can you give us an example of how you think that might play out, or if it's played out already?
It is in the primary care space already. Okay. So the notion that we have to open a computer and start documenting is going to be obsolete. You can have a conversation with the patient and the documentation could be a byproduct of it.
Yes.
So that obviously is very native for a primary care space. But can we take some elements of that one into AIM space for documentation? And more importantly, us as perioperative physicians, can we incorporate this technology into our daily clinical care? In other words, just getting the history and physical or periop journey of a patient without actually cleaning through records and records of their past medical history, past surgical history, their labs as a trend. That should be conversational within electronic medical record. So I see a step where the UI becomes much more sleeker, easier, uniform. But the bigger play is actually the data and how you can actually have a conversation with the data in terms of patient care.
So you should be able to go into a chart and type that you want to know someone's labs or something like that and say, I just want to know what their potassium was.
What's this type thing? We've just heard we can drop that.
Yes, we should take it to the next level where you actually should have a conversational analytics conversation with the data itself.
I'm so stuck, ingrained into everything as a type. I'm having a hard time making that connection. So how do you feel that, putting AI into our practice, how do we get anesthesiologists, CRNAs, everyone in this space to adopt this?
So we're always afraid that something going to replace us, or number one and two, that the machine doesn't have to tell us how to practice medicine. That's not the notion here. It is here to help us practice better, make us quicker, faster decisions quickly. No technology is going to ever replace a physician or a clinician, but it's going to make it more safer, easier. And in this environment where we have a shortage of anesthetists around the world, if you look at, so we have this notion of locums and a revolving door of providers coming through. They don't have to learn a new EMR. There are electronic medical records. So it should be easy. That's half the stress when you start a new job.
Sure, absolutely.
So if you can take that away by making it agnostic, where you can actually have a conversation, that would definitely help. So when you put these conveniences ahead in front, not as a replacement, I think that's going to help adapt. Anesthesia providers adapt this technology.
It should be easy as picking up, the new cell phones that you can just, start using the minute you take it out of the box. That's pretty much, right?
That is correct.
Here, Ronald G. Pearl, ASA Committee on Innovation, Professor and Chair of the Department of Anesthesiology, Perioperative and Pain Medicine at Stanford University School of Medicine, explains.
Yes. So when we talk about AI, I think it's important to realize that we're not talking about a single technology. Artificial intelligence has been part of much about our technology now for decades. Every time we're using processed EEG in the operating room, that is a AI-driven technology. We have AI for very specific purposes. And then what we're often talking about is much more expanded AI. The generative AI, like you see in ChatGPT, is very, very different than much of the AI systems that we're talking about, which are much more sort of statistical, trying to predict, diagnose, categorize factors. And often people think about AI as being human level general intelligence. We are so far away from that right now that is pure hype at this point in time. But, as we think about this large spectrum of AI, we need to be fairly specific about which things, and so some of them are accepted, some we may never see, some may be 5-10 years away.
Yeah.
All of the conversations we're referencing here in this program are available in full on TopMedTalk. There are links in the show notes. We highly recommend this one, though. It's on the subject of hemodynamic instability. Louise Sun explains her role in the research.
So I'm a professor and chief of cardiac anesthesiology at Stanford University. My role with Anesthesia Patient Safety Foundation was as a panel member on the hemodynamic instability group.
How was your experience there being on the panel and part of this? And what did you feel like were some of the biggest points of conversation and maybe disagreement or, things that you thought were big conversations?
Yeah, so it was a great experience. Like my colleagues have stated already, we had stakeholders from all areas. I participated as one of the people who generated some of the evidence in the area.
Okay.
Our group had attempted to define critical thresholds and durations of hypotension in association with a number of organ injuries in non-cardiac and cardiac surgery. And, I certainly met a number of clinician scientists who generated evidence in the similar area, as well as on wearables and AI machine learning algorithms, as well as stakeholders in the industry who were much involved in the space. So I think it was great. And what's even more great about the consensus conference was the lack of consensus, which generated a lot of very good, heated conversations that we carried over even after the event. So, we divided up into a number of writing groups afterwards, up to, I think, about 5 or 6 people per writing group. And even during the writing process, there was a couple of
debate.
Yeah. And something as simple as how do you even define hypotension took us quite a while to nail down.
Yeah, I would have assumed that just being in multiple conversations about this with large groups, it is hard to kind of come to consensus. And, I think you mentioned hypotension was what started this conversation. And I think those of us who talk a lot about it has really morphed into maybe the hemodynamic instability more than just intraoperative hypotension. And Louise, what are some of the recommendations? I know you said you helped develop some of the statements. Were a couple of those that you worked on?
Right. So I'll probably speak specifically to the definition of hypotension.
Yeah.
In a broader sense, the statement is about hemodynamic instability. It's a pretty complicated concept that actually involves a number of vital signs all interacting together. But blood pressure seems to be the most commonly used surrogate for describing instability. And blood pressure itself is actually a complex interaction of many things like cardiac output, stroke volume, systemic vascular resistance, viscosity of the blood, and the elastance of the vasculature. So there's been many studies that have been produced to date. With respect to AKI or acute kidney injury, the consensus is that MAP less than 55 is definitely too low.
Yeah.
MAP less than 60 is likely associated with serious harm, whereas MAP less than 65 is perhaps unacceptable as well, relative to end organ injury. And with respect to MINS or myocardial injury after non-cardiac surgery, the evidence is fairly similar with respect to blood pressure targets. Now, there's been the POISE-3 trial that came out recently that sort of muddied the water a little bit for us in that, they compared basically two strategies, right? In one of the factorial designs, they looked at hypertension avoidance and hypotension avoidance. So basically, when it boils down to is MAP of 60 versus MAP of 80 as the target. So they actually didn't find any differences in their primary or secondary endpoints, which included, major vascular complications, MINS, and mortality, and a number of other things. So that's why one of our conclusions was that MAP greater than 80, doesn't seem to give us any benefits, but we do recommend keeping MAP above 65.
Thanks for downloading TopMedTalk. Don't forget to subscribe. I hope this short program has whet your appetite for an incredible conference coming up this weekend, Anesthesiology 2024.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.